What is good, YouTube? Hey, it's Jay, and I'm back again tonight with another video. I'd like to welcome you back to Respiratory Therapy Essentials for the TMC exam. All of our content is about you passing the TMC exam on your first or very next attempt. Now, tonight we're talking about pulmonary function testing. Now, I did a video on flow volume loop, so make sure you go back and review that video. But tonight we are talking about content that would help you pass the TMC exam on your very next attempt that relates to pulmonary function testing. Are you ready to go? Let's do this. Okay, guys. Tonight, as always, we start at Roman number 1, working from left to right on the board. And we want to talk about pulmonary function testing. And like I just said, we did video on flow volume loop that will kind of go in conjunction with this lecture. So make sure go back and take a look at that video. Now, the indication for PFTs, we'll begin talking about restrictive diseases, is to, number 1, find out if the patient have a lung disease. And then we want to know what is the disease progression. And we want to determine the type of therapy that the patient should have. And we also want to find out if the patient can perform the test. Those are the indications for PFTs. And yes, they are on the exam. Now, there are also bedside PFTs on the exam that include the FEV1 second, the forced vital capacity, the inspiratory capacity, and flow volume loop. This is information that if you have not studied recently or don't feel comfortable with, then you need to listen to this video. Now, the procedures in PFTs are, and I'll take them one at a time without listing them, because this is the main one. The procedure in PFTs that I want to talk about, starting with the slow vital capacity, or SVC. The slow vital capacity is the maximum volume a patient can exhale after maximum inhalation. Now, this is a good test to measure restrictive disease. What do we use to determine restrictive disease? We use a slow vital capacity. Now, the slow vital capacity should always be higher than the forced vital capacity, and we'll talk about next. If the forced vital capacity is higher, then you need to repeat the test, because this usually means that you got a poor patient effort. The slow vital capacity should always be higher than the forced vital capacity. So then what is the forced vital capacity? It is the maximum volume a patient can exhale after maximum inhalation in the least amount of time. So that means that they're blowing it out really quickly. They taking in a deep breath, and then they blowing it out as fast and as quickly as they possibly can. That is a forced vital capacity. Now, it is also used to determine restrictive disease, but it's not as good as the slow vital capacity. Another thing you need to remember about the forced vital capacity is that it is both a volume and it's the name of a maneuver. When we use the forced vital capacity maneuver, we measure flows and volume, which is basically the FEV1. That's how we get our FEV1 is from forced vital capacity, because it is that amount of air that you can blow out in that first 1 second. In the middle of the board, Roman number 2. These are stats and facts and ranges that you must know for the exam. Everything on this board you will see on the TMC exam. Now, the best indicator for obstructive disease, and we just talked about restrictive. Restrictive, slow vital capacity, forced vital capacity. Now we're talking about obstructive. The best indicator is your FEV1, FVC percent. It is the best indicator to find out whether or not your patient has obstructive disease. The second best is the FEV1 by itself. Normal is 85%. Acceptable is 70%. Whenever your patient has an FEV1, FVC percent less than 70%, the patient is obstructive. The forced vital capacity is used to evaluate upper airway for the presence of vocal cord dysfunction, paralysis, and cancerous masses. If you want to know why we want to use the forced vital capacity, there you have it. It's to evaluate vocal cord dysfunction, paralysis, and cancerous mass. You will see that on the TMC exam. And the next, we have flow volume loop, cancerous mass or paralysis flow volume loop will look like. And we call it a pancake because it's both flat on the top and flat on the bottom. You see any kind of diagram on the exam like this, then you know that it has to do with a cancerous mass or vocal cord paralysis. Now, the body box. The body box is used to measure functional residual capacity and thoracic gases. That's the FRC. It's also used to measure airway resistance or RAW. The body box replaces the use of nitrogen washout and helium dilution. Now, the normal RAW is 0.6 to 2.4 centimeters of water. For those patients who's on the ventilator, and most of your patients will be, then the normal can go up to 6 centimeters of water pressure. An increase in PIP will cause an increase in airway resistance. Increase in PIP will cause an increase in your airway resistance. Dlco. For some reason, we always overlook the Dlco, but it's on the exam. And I'll show you what's on the exam. The Dlco is a measurement of how well gases, your O2 and CO2, moves across the alveolar capillary membrane. A normal Dlco is 20 to 25. A poor Dlco are found in restrictive diseases. I'll place emphasis right there because the next information part of this is you need to really understand. A poor Dlco is with restrictive diseases such as ARDS. However, emphysema is the only obstructive disease associated with a poor Dlco. Why? Because it involves destruction of the alveoli where gas exchange take place. Now, we also do what is called a pre and post bronchodilator study. And these are used to determine reversibility of bronchial constriction in asthma patients. To be reversible, you must have at least 12% more increase in the flows, or the FEV1 should increase more than 200 milliliters. Please hit that like button, subscribe to my channel, turn on your post notification